You are listening to the Addiction Files, where we discuss evidence-based treatment, clinical pearls, and resources while striving to destigmatize the treatment of addiction in our medical culture and save lives. We are the Addiction Doctors, Dr. Darlene Peterson and Paula Cook. Welcome to the Addiction Files. We are thrilled. It is such an honor. Tonight we have Ray Sweet joining us to discuss suicide prevention. And this is such an important topic. And we were just discussing that I don't know why we haven't done this before, but with substance use disorders, this is a difficult and sometimes really challenging area for us as physicians. And so we are just thrilled, Ray, that you have joined us tonight, because this is an area that you are definitely an expert and really passionate about. So I'm going to turn it over to you to introduce yourself and then kind of give us an introduction to this topic, and we'll get started.
Great. Thank you so much for having me. My name is Ray Sweet. I use they, them pronouns. I am non-binary and also identify as transgender. I'm a person who has some lived experience with suicidality and mental illness. From an educational background, I have a master's in social policy from the University of Pennsylvania's School of Social Policy and Practice, where I focused on youth development and barriers to educational attainment, mostly focused on mental health. And my sort of other areas of interest are rural mental health, using sort of crafting and other tactical things as a form of suicide prevention, and healthcare for LGBTQ plus people. I currently oversee some of the state of Utah's youth suicide prevention programs with the Department of Health and Human Services, Office of Substance Use and Mental Health. These are all my own opinions and don't reflect the views of Utah's Department of Health and Human Services.
Awesome, Ray. Thank you for joining us. So before we talk about this, you kind of just glossed over this interest and knowledge of using crafting as suicide prevention. So can we just talk about that first, please? Because this is really awesome.
It's something that I'm trying to integrate more into my day-to-day job, but it's something that I've used myself as a way to sort of mitigate suicidal feelings or behaviors. So I am a crafter. I like doing embroidery and knitting, really any sort of handcrafts. And I get a lot of joy from that. It's meditative. It is a low stress way to sort of create something and have this outcome through sort of a meditative and creative process. So, on the research side, doing, especially embroidery has been used in mental health settings for a long time, throughout history. There are actually women who have been, in mental health inpatient situations who have used embroidery as a way to sort of help cope with mental illness. And I also grew up in 4-H. So I was a member of 4-H clubs, and I really loved the community aspect of crafting together. So sort of an old idea, but like a quilting bee or a sewing bee, where you get together with other people, you have something to do with your hands, but you're also connecting. And so I really want to more mindfully bring that to suicide prevention, that it's not just sort of, not that it's boring, but the more traditional ways that we might address suicide prevention, and think about ways that are more tactical and that are also about developing a coping skill.
Wonderful. That's really great. Love that. I can attest to your crafting prowess. You're quite talented. Your cat attire that you craft is quite remarkable.
Thank you.
Cat wigs. So tell us a little bit about, why is suicide such an interest? Why is it so important? Darlene and I sit on the side where we're always trying to kind of soapbox and advocate for substance use disorders and the high morbidity and mortality related to substance use. being acutely aware that the suicide epidemic, as it's kind of called, and suicide rates are alarmingly high as well, and they deserve just as much attention in terms of what's happening, why, what are the risk factors, what can we do about it? So what's kind of the state of affairs in at least in the US?
Yeah, and I think it's a topic people are afraid to talk about. A lot of times there's a lot of stigma associated with it to begin with, but then I think even, or especially for professionals, there's sometimes a fear because, if a client dies by suicide, that might in some way feel like a reflection of your own practice. And it feels like the stakes are sort of high sometimes, right? So I think it can be scary and people don't want to think about it, which really doesn't help the problem, right? So I've been on a general increasing trend since the 90s. And especially in the Intermountain West of the US. So sort of around the Rocky Mountains is what sometimes is referred to as the suicide belt. And that's where our highest suicide rates are in the country, along with Alaska. So there's very big differences. I mean, the US is a giant country with a very fragmented medical, like healthcare system and mental health care system. Um, Treatment varies wildly, is not always well sort of managed or regulated. So there's a lot of difference. And then culturally, there's massive differences from one state to another state in terms of, dominant religious ideas or, like where we are, there's a lot of firearms. And that's a big part of culture in Utah and in the Intermountain West. It's just a lot of people carry firearms regularly. And that, if that's the case, then you're going to have to be talking about suicide prevention because those firearm deaths are going to make up the majority of suicide deaths.
Ray, I have a question about that. So, this phenomenon of the Intermountain West, or this belt that runs from kind of Montana down to New Mexico with the highest rates of suicide in the country. So, do we attribute that to the availability and the carrying of firearms? Or I know there's been some other theories about like altitude. What is most accepted in terms of those states?
Yeah, so we do hear a lot that it's because of the high altitude, and there might be some evidence around like the efficacy of medications at higher altitudes. So possibly that is in one way maybe why suicide rates might be higher. But in my on my team, when we're talking about it, first of all, the altitude in Utah has not gone up since the 90s, right? Like we've stayed at the same altitude, but our suicide rates have gone up. And also, as a public health person, I can't change the altitude. So I think that's an appealing explanation for our high suicide rates. But I think that it sort of makes it so that we don't have to do as much, right? So, but yeah, so we hear that a lot. I think personally, from my perspective, it's very isolated because of the mountains. So people are in more isolated communities. You can't travel as easily, and just a lot of really rural areas. So on the East Coast or other parts of the country, you can maybe get to a big city pretty quickly. But in the Intermountain West, you might have to go several hours to get to where there might be available treatment or connection with other people. So, but we do see correlations between availability of firearms and suicide rates. So that definitely is a big factor. And I think also, we do hear a lot that like youth suicide is this massive problem. It's an epidemic. It's like, we talk mostly about youth suicide, and I work in youth suicide, but the numbers on that can look kind of misleading, right? Because young people even if the number one cause of death is suicide, young people don't die that often. There aren't that many causes of death for young people. So we can say like it is the number one cause of death, but it's not competing with heart disease or cancer, these other diseases that people who are older often may have in their life. So it really is middle-aged men who are the most at risk for suicide. And, that's for a lot of reasons. I think some of it is cultural, about men not seeking that connection or like support. Men are more likely to choose a firearm as the way that they attempt suicide. And literally anything else is less fatal than a firearm. So using other means, there's a higher likelihood that you won't die by suicide. But if you use a firearm, it's very good at what it does. And it's likely that you will die by suicide if you use a firearm. So, yeah, I think that's really interesting because before I got into this work, I really did hear like for young people, like it's such a big problem. And it is, no young people should be dying by suicide. But it's interesting to see how much it is middle-aged men um, in actuality.
Yeah, that's distressing. What about suicide rates by area of well, I think that we're talking about Utah data, but area of the state, and it probably relates to other states as well, I imagine.
Yeah, so more rural areas tend to have higher suicide rates, which happens in Utah definitely. Some of that is um, like I have to say on a statistical level that there are fewer people in rural areas. Therefore, every suicide death um, will increase the suicide rate more quickly than in, say, a big city, right? Because there's a lot more. So by count, there may be more suicide deaths in a city, but by rate, it's usually rural areas, which is often to do with lack of access to mental health services, maybe a culture of sort of bootstraps, not relying on anyone but yourself, and that availability of firearms.
Yeah, that makes sense. I mean, I think as a person who practices in like the behavioral health arena in a rural area, it also seems like there's more alcohol use disorder, more substance use disorder, which correlates, and there's less help seeking, even for help that is available. There's more of a like, we just do this. This is our family. We just don't access care, even if it is available. But that makes sense.
Yeah, I think there's a misconception that rural areas, like you think of urban areas as places where there's lots of drugs and that sort of thing, but it's equally accessible in rural areas, and there's just maybe not other things for people to do. Like if there aren't other activities to be doing, I feel like sometimes maybe substances become what you do. Um, and also as a way to, self medicate. So yeah.
Right. And we just released an episode on treatment and harm reduction in correctional settings. It actually just came out just in the middle of May. And death by suicide is number one. I mean, you know this, but is the number one cause of death for people who are incarcerated.
Mm-hmm.
And being incarcerated, you're more likely to be incarcerated if you are a person who uses substances in a rural area than you are. So all these risk factors, I guess, add up. And so for our population, it's just this accumulation of risk.
Mm-hmm.
But speaking of which, tell us a little bit about, we talk a lot again about in substance use disorder. We try and use person-first language and try and destigmatize the conditions where people find themselves seeking treatment for substance use disorder. What about for the language around suicide?
So we try and move away from certain language that is pretty common. So in the field of like public health and suicide prevention, we try not to say commit suicide, which I would say is the most common way people often say it. Just because commit sort of suggests that it's a crime or a sin that that's like what that verb is usually used for. And then you also hear like completed suicide, which sort of has an idea that it's almost a good thing. Like, oh, I checked that off my to-do list, which is not, it's not a good thing to die by suicide. And then we hear successful or failed suicide, which again, these are sort of like value judgments on the suicide death. And so I try and always say die by suicide. That's, I find, the most neutral way of saying it. Sometimes people get a little curious about like, well, what does that mean exactly? And I find that saying die by suicide is similar language to saying that like, well, they died like from cancer or something. Like there's not really anything else to be said there. Um, Whereas sometimes when we talk about like committed, that's sort of they did an action. And I want to know more about what that action was. Like how exactly did they die? So that's some language that we try to avoid. And then again, person first language of not saying like someone is suicidal, but saying someone experiences suicidal thoughts or behaviors or is a survivor of a suicide attempt. Really try, and when I'm saying we, I just mean like the suicide prevention community tries to focus on hope and recovery when we're talking about suicide. So that recovery is possible, that suicide is not like a foregone conclusion for anybody, even if their risk is very, very high. So we just try and it's really hard to stop saying some of these things. I think as anyone knows who's tried to change the way that they speak. But yeah, I think I've been doing this for about 5 years now. And now I think I'm pretty good all the time. I'm sure I do slip up sometimes, but it's always, I think, a good thing to try at, using that less stigmatizing language.
Yeah, no, I'm going to try. This is great because I'm definitely, I have not been using the correct terminology. So,
Ray, can you tell us a little bit, what does the statistics look like for those who die by suicide with substance use disorders? How much more common is that?
It's a lot more prevalent. So the statistics that I've seen show that in about 40% of suicide attempts, there is some sort of substance in the system,
Wow.
often alcohol or opioids. So opiates were present in 20% of suicide deaths, in a study from 2018. And then marijuana was in 10.2%. And then going down, cocaine is about 5%, and then amphetamines. So, but alcohol and opioids are really the ones that we see most often, that someone usually has those in their system when they attempt suicide. And I think what's interesting to think about there is, that substances can impair can increase disinhibition, right? So can make you more impulsive. And what we know about suicide attempts is that often people have only been thinking about the attempt for a really short period of time. So a study was done of people who had attempted suicide, and went to the emergency department and were asked, how long were you thinking about, like from the moment you said, I'm going to attempt suicide to the moment that you did? And for most people, it was about 10 minutes or less. So it's a really short period of time. And then when we're adding on something to create even more, like even less impulse control, then those things are definitely going to have a multiplicative of, effect. Like it's going to create a situation where you are going to be more likely to do something that maybe you wouldn't, if you were not using substances at that time. But yeah, so people who use substances, people who are alcohol dependent or who use drugs are about 10 to 14 times more likely to die by suicide compared to
Wow.
the rest of the population. So it's a pretty significant risk factor.
It really is. And then I don't know how much data you have. When I was just reading about this topic, then when you add in substance use with a mental health disorder, what does that look like?
Yeah, let me see, like, actually the numbers that I don't have memorized, but I mean, first of all, there's so much comorbidity with substance use disorder and mental health
Yeah.
disorders. And I am constantly frustrated by the sort of siloing of mental health and substance use disorder, because to me, substance use disorder is a mental health disorder.
You
It's
and
in
me
the
both.
DSM.
Yes.
Yes.
So I always find it strange to say that those are like distinct, and they obviously feed into each other so much, right?
I think it's
So
fascinating. Sorry to interrupt, but
yeah,
I was just reading, I think it was from, oh my gosh, I think the Journal of Psychiatry on exactly that topic. It was just saying that this is adolescence, is talking about with bipolar, which is the highest. And I'm sorry you would tell us this, but
yeah,
adolescents with suicidal behavior who have bipolar, the highest risk of, unfortunately, completing suicide. And and they also see, if they use substances, then they have it's going to bring out that bipolar behavior earlier and then increase that suicidal risk for them. And I'm like, that's so interesting, but we've seen that in clinical practice, and so frustrating as well, because it's like you said, these aren't occurring, these are co-occurring, they're not occurring separately, and then we're trying to treat them and missing this opportunity.
yeah. And I think sometimes we do run into situations where we want to separate them and say, well, we should treat the substance use disorder before we treat, maybe these suicidal thoughts,
Yeah.
and it's really just one ball of things that we need to address. Like, you
Yeah.
can't really tease out, okay, let's fix the substance use disorder. It's just not, I mean, to my mind, that seems impossible to separate that from both mental health disorders and any sort of suicidal thoughts or behaviors. So, yeah, so like you said, people who uh, have bipolar disorder is going to be the highest risk for suicide. And then um, unipolar affective disorders would
Yeah.
be second, then schizophrenia, and then anxiety disorders, as sort of the hierarchy from
Makes
highest
sense.
to lowest risk. Yeah.
Yeah.
Um, and then some personality disorders as well might cause increased risk as well. Specifically, borderline personality disorder has a incredibly high suicide
Yeah.
rate. Um, yeah. And something that on a personal level, I think people don't talk about too much is so I am a person who has PMDD, which is premenstrual dysphoric disorder, which is kind of like PMS, but like in a
Higher
life
level.
ruining way.
Mm.
And so until I sort of got my medications right, every single month for several days, I was in a state of just like intense, acute feelings of, suicidal ideation. And we don't talk too much about those like intersections between um, sort of a hormonal problem, possibly, and then like mental health problems. Um, and that those things do go together and can cause problems when you're trying to get treatment as well, right? In a way that sometimes if you have a substance use disorder, it might be hard to get treatment for something else because people say you're too complex. Like, I don't know how that works with the other things going on. So yeah, I think it's something that that all parts of medicine need to be thinking about.
Just thank you for sharing that, Ray, because I think
Yeah.
you touch on a really important point between physical pain and physical symptoms that people have and chronic pain. Both of
Yes.
those significantly increase risk of suicide. And again, you can tell, I don't know the exact statistics there, and you could tell us that, but I think that's often overlooked. And like you said, those rapid shifts, like in mood with those hormonal shifts, is significant, is probably a significant risk factor, and probably that association why bipolar is particularly top of that list. But like you said, you're experiencing the same with that PMDD. That's very interesting as well, and hard.
It sort of mirrors a little bit of borderline personality disorder, but like just for a shorter period. But it's very disruptive to your life, right? Like
Absolutely.
to feel that way for several days of the month was it's not good for work or relationships, which then further is going to increase, you're isolating.
Takes away your
I'm very
protective
happy
factors.
Yeah, I'm happy to have found the right treatment for myself for that. But yeah.
Talk to us a little bit about, we talked a bit about risk factors. What about protective factors, and how can we move forward with kind of identifying how to keep people safe?
And I will also say that when we're doing suicide prevention, we talk a lot about shared risk and protective factors. And so this can be, happen in other sorts of public health, or like other health disorders where there are maybe shared risk and protective factors for certain disorders. But when we talk about it in suicide prevention, it's usually about substance use disorder and suicide. So there's so much overlap between the risk factors, like some things we've talked about, that substance use is a risk factor for suicide, but things like family conflict, trauma or abuse in your background, chronic pain, which may feed into substance use. So there's a lot that's similar there. So we do a lot of work with substance use prevention folks, just because we're sort of working towards the same factors. But on the protective side of things, things that are going to help mitigate your suicide risk, sort of what I was talking about with the crafting. So having coping or problem solving skills, having something like distress tolerance, DBT type skills can be a strong protective factor. Connection with other people. So especially for young people, having one trusted adult in your life can really counteract like a lot of risk. It doesn't need to be a parent, but just some trusted adult in your life. And having a sense of community involvement, community connection, which again is something that I'm trying to push for more projects that involve, community greening or a community art project, that sort of thing. Things that help bring people together to support each other, but not necessarily just saying like it's for suicide prevention, right? Because that's not, I don't think I would want to go to like a club that was just about suicide prevention. But to meet other people and learn a skill together is suicide prevention. So family support, super important. Sometimes having cultural or religious beliefs that see suicide as taboo, or discourage that can be helpful. I will say sometimes feelings of alienation from religious groups or cultures, dominant cultures, can be a risk factor. So that one is depending on which side you're like, are you feeling very welcomed and part of a group? That's going to be protective. But if you're feeling isolated from that group, it's going to possibly be a risk factor. And also receiving treatment. So if you're receiving treatment, that's something that either mental health treatment, substance use treatment, that's going to sort of lower your risk. Also, more opportunities for someone to intervene, which is why we really want to promote that all clinicians, all providers are screening their patients for suicide risk every time that they see them. So it's something that's not done frequently, but is something that doesn't need to be done even by a licensed, you don't need to be a doctor to do a suicide screener. So having that regular check-in is something that's really going to help lower suicide risk.
I think that's so interesting. And there was a couple of studies that talked about having a good rapport with like your physician or your mental health therapist was very protective. But then there was also it was a risk factor if there was a departure of your, so if a physician leaves the area or your mental health therapist, quits and leaves, then that was actually shown to be a risk factor for increased suicidal behavior. So, I mean, that's a little bit sobering for us as physicians just to know that, making sure we have these warm handoffs for our patients and they're very vulnerable. And then to be interesting, Paula, you weigh in because we both have worked in OTPs. They found that patients actually involved in methadone maintenance programs actually had, even compared to other treatment programs, had a 20% reduction in suicide risk. And I found that really fascinating. And you can kind of tell me your reasons that why you think that is. And Ray, I mean, I'm sure you've heard this as well, but I just kind of thought I've just watched our staff who are so amazing because I really think part of it is it's a community that you just talked about, Ray, that for patients who come in and it's the secretary knows you, I mean, they know you and
Yeah.
it's just, you're coming in every day. And if you don't come in, they're calling you and someone's, and it's just a built-in community for really vulnerable people who really need that help. I mean, that was my thoughts. Paula, what do you think?
Yeah, I didn't know that statistic, but it makes a lot of sense. And I think you're exactly right. I think it has to do everything with community and it has to do with seeing the same people every single
Day
day
in.
care about you. And I agree, our staff, the OTPs I've worked in over the years are
Amazing.
typically amazing, particularly the staff that I work with right now. I mean, the nurses know every single person. They know what time they typically come and dose. They start worrying about them if they're even like 30 minutes late. And they start, they'll call them. And just people support each other. And, there's just this congenial community sense of uh, purpose from getting treatment together. And then, of course, OTPs require counseling too. So you have lots, I think, of protective factors within that system. So that makes a lot of sense. And so another reason to kind of just put in place these things Ray is talking about, where you have reason to get together, not necessarily treatment focused. It could be crafting or walking or gardening or, I mean, obviously methadone and buprenorphine clinics in an OTP setting is treatment focused, but are protective. I think that's a really cool study, Darlene.
Caring contacts is this idea of sort of non-demand personal outreach to clients, especially clients at risk for suicide. And it started, I believe, with veterans and sort of veterans like reaching out to each other and saying, hey, I'm thinking of you. It's not something that says, so this can be like texts, handwritten cards, just a phone call to say, we're thinking of you, we're here. I'm not asking you to do anything. I'm not asking you to come in or tell me how you're doing. Nothing. There's no expectation. It's just a light reaching out to someone and saying, hey, we're still here, just to remind you that like you have support and we're some of the people who do support you. And I wish I had the exact statistics, but it's like such a small thing that has like a huge impact on suicide risk and that feeling of belonging and like reducing that perceived burdensomeness that sometimes happens with feeling suicidal thoughts, having suicidal behaviors. So something that I really try and promote, and also something that doesn't need to be done by like a clinician, right? Peer support specialists are great people to be doing this. So there's ways to increase services without adding burden to maybe some of your like licensed staff.
So cool. Did you call that caring contacts? Is that what you call that?
Yes. Yeah.
That's really great. January Riggins, who she was on our podcast in season 1, I think. She runs an amazing nonprofit in Salt Lake City, outreaching to sex working and sex trafficked individuals and also people who use drugs. She started her nonprofit just by delivering handwritten notes and basic hygiene kits to hotels and motels with no other resources, like no harm reduction supplies, no treatment. Just we love you. You're special. Someone cares about you. Here's some deodorant and soap. And her program was just to go to some of her fundraisers and hear people respond to how that impacted them is really powerful.
Yeah, I think there's a perception, and part of like the fear about suicide prevention or interventions is that like there's something very specific you need to be doing, like a clinical protocol or something you need to follow. And there's all these things that you can do that are far outside of what we would maybe traditionally think of as treatment. That has like a really big impact on suicide, and that I think that we should be more trying to promote. Is that Soap to Hope?
Yes.
Correct.
Yes. Yeah. So these like programs that just create a sense of belonging or connection, just like connection is like one of the most impactful protective factor. So
That's awesome. Tell us about other resources, because obviously I think a lot of our listeners are maybe clinicians or learners or obviously in like addiction services. What other resources can you offer? I mean, I think that's enormously helpful for me personally. I'm going to institute some of that for my team and for folks that are in our community. What else can we do, and what else can we offer people before they are experiencing suicidal thinking or experiencing suicidal behaviors, and when they are in the midst of those?
so there's something called the Zero Suicide Framework, and it's a whole healthcare system, but it's also just sort of a philosophy about how we deliver care, and that is sort of that everybody in a mental health facility, from the doctors to front desk, has a role to play in reducing suicide risk. So we might recommend something like QPR, which is stands for question, persuade, refer, and is a gatekeeper training. So that's a way that you can identify people who might be at risk for suicide, helps you learn how to ask someone if they're thinking about suicide in really direct and supportive way, and then how to help refer them to get services. So that's something that's really great for non-medical staff. And then I think also for clinicians, I think it's great to, especially in rural areas, there's a training called Counseling on Access to Lethal Means, CALM. It's a free online training. It's about an hour, and it just helps providers have conversations with their patients about access plans for access to lethal means if a sort of suicidal crisis or mental health crisis might arise. So having a plan in advance to say, hey, you have firearms, how can we keep you safe? Or what's our plan if something were to happen? And I think some other, there's so why I wanted to bring up the Zero Suicide framework is that, and maybe I can give you the link to share this. They have a list of evidence-based trainings that you can take. A lot of them are free. Oftentimes your state health and human services, whoever is overseeing mental health and substance use treatment, will have free trainings for that sort of thing. There's a lot of funding usually at that state level. So checking with your local health and human services or human services in your state can be a great place to get training, both clinical and non-clinical type trainings. But on the crisis side, first of all, we have the suicide prevention Lifeline, which is now anywhere in the US. You can dial 988. So instead of the long number, you can just dial 988.
And that is like US and Canada now.
Yes. And that, I will say, and I know that it's being worked on, but it will route you to the crisis line that is in the same place as your area code. So I have, my phone number has a Buffalo area code because that's where I'm from. And so if I called 988, it would route me to the Buffalo, like the New York State crisis line. You can usually find the local line, like there's a line in Utah to just get straight to the Utah crisis line so that there's more tailored service, like resources. And then we also have in Utah, but other states, things called receiving centers. So these are places that are sort of like an emergency department, but just for behavioral health, mental health crises. So they are walk-in, and the staff is more aware of mental health disorders. Sometimes, going to emergency department, the staff might not be that familiar with how to deal with someone who's in a suicidal crisis, or maybe feels uncomfortable, or I think we've all heard like stories of people going to the emergency department and it doesn't feel very good. Ends up being sort of a almost traumatic experience. So receiving centers are cropping up to sort of divert people from the emergency department and also get them to people who know how to work with people who are in crisis. So I think looking to see if you have receiving centers in your area, advocating for those if you can, on a policy level.
How do you explain that receiving center business? Because it's a little bit of a mystery, the logo of receiving centers and, those kinds of things. So I'm glad that they're available. And, from someone with family members who've experienced suicidal thinking, it's really distressing, obviously not only to the person who's experiencing suicidal thinking, it's got to be so painful, but it's really painful and distressing to family members to be with them and to go through like traditional medical emergency and crisis services where you end up in an emergency room for hours and hours or longer, and you're stripped into a gown and you don't have access to a phone. It's really distressing. So hopefully we continue to build on crisis services that are much more humane and trauma-informed and caring for people so that they're not more traumatized. I was just talking to someone this weekend who was struggling and really needed to have some acute care, mental health care. And I suggested that they go to the emergency room, and they were like, absolutely not. That is the worst thing I could do for my mental health right now, is go into a room, be stripped of my clothes, and be left alone for 6 hours. And I couldn't disagree with that. So I'm glad to hear that there are some other resources available and go from there, and especially mobile teams too, like you mentioned, that they're available.
Yeah, and I think it's also important if you're helping someone who's in crisis to like listen to the reasons why they don't want to go to the emergency department. Maybe like sometimes you might just want to sort of say you have to go there, like that's what has to happen. When there's really valid reasons to not want to go there, especially for people who are maybe LGBTQ or people of color who have poor experiences with law enforcement or with, the emergency department type arena. Like there's a lot of really valid reasons that you wouldn't want to go. And not to say that they shouldn't go, I think though, but being aware and then maybe finding someone who could go with them and help navigate that situation. If we have more people who can be more aware of suicide, even through like these gatekeeper type trainings that we do, that I mentioned earlier, then we can help them help others navigate situations that might be stressful. And I think sometimes people don't know that if you have someone that who is experiencing a crisis, you can call the suicide prevention Lifeline. Like you can call them and say, hey, this is, I'm with someone or I'm worried about someone, and get some advice from people who are trained. And you could also say, hey, let's call the 988 together. So there's lots of ways that you can if you are not in crisis, to help someone who might be in crisis navigate things that could sometimes be difficult, even if you're not in crisis, right? But to have someone sort of shepherd you through that.
That's really great advice, Ray. Thank you
Yeah.
so much. And thank you for those resources. That's something I think we can all use.
Thank you. And I wanted to just mention to our listeners who may have missed, this is kind of jumping ahead, but or backwards maybe. But we had an amazing episode a couple of months ago on grief and resources for people who have lost people, to suicide, people who've died by suicide. Kathy Supiano was our guest, and she discussed specifically the special kind of acute grief that people do experience when a loved one dies by suicide.
Overdose. Yes, suicide or overdose.
Suicide or overdose, but particularly, I mean, both, but particularly suicide carries, like you said at the beginning, Ray, a lot of stigma and shame. And we would be taking flowers and casseroles to people who die from any other cause, but often communities don't know how to respond. And so this is kind of an extension resource, but there are some good resources out there for people who need support for loved ones who have died by suicide. And there's more information on that podcast, or you can look up, it's Caring Connections through the University of Utah School of Nursing.
And a wonderful job.
Supiano is the PhD researcher who leads that program, and they offer trainings around the country for caregivers and clinicians
and programs,
teams, programs for leading grief counseling for those people.
We love Kathy Supiano at my office. So,
good. Yeah, I bet you do.
Yeah. Yeah. And sometimes it's helpful to know that what we call those times after there's been a suicide death or a sudden death, maybe like an overdose, is called postvention. So if you're looking for resources, sometimes looking up postvention can be a good venue for that. But but Kathy Supiano is great, and it is a very unique kind of grief. It's something where sometimes we do trainings, and folks might want to join those trainings too soon after they've experienced a suicide death. So, or even if it hasn't been too long, because we'll get questions like, or people sort of feeling guilty, like, well, there's all these warning signs that I should have seen. Why didn't I see all of these things that I've just learned right now existed? Do what we do based on the information that we have at the time. So, but there is a lot of guilt usually associated with, if someone has experienced a suicide loss, learning about suicide warning signs can sometimes feel like brings up a lot of feelings of guilt. So just, that's something to be aware of, that people might feel like, I should have done something. I should have known. No, we don't always know. And we're not always in a position to help. We can just educate moving forward.
Thank you for saying that. That's really powerful too. And I mean, unfortunately, I think all clinicians will have patients who die by suicide. And we talked about this with Kathy Supiano. We needed a therapy session with her, actually. Darlene and I did.
We did.
It was terrible. It was a terrible amount of grief and guilt around having a patient who dies by suicide, because you really do feel responsible, and you just cannot let it out of your mind of what else you could have done or should have done. So, yeah, I love that. Well, what else? Is there anything that is left unsaid, Ray, that we need to say that we want to finish up with, or any final points?
I guess one thing I did want to bring up was safety plans. So safety plans are maybe what it sounds like. It's a plan for if you're in a suicidal crisis or mental health crisis, what are you going to do to keep yourself safe? And it's usually information about, how do I know that maybe I'm going to be triggered and have, experience a crisis right now? What are things in the past that have sort of precipitated something like this? Who am I going to contact specifically? It's very specific, a safety plan. Like, I'm going to call Paula if I'm in crisis, and here's her number. So some coping skills that we might have, maybe I can listen to music, or I can go for a walk. Because sometimes when we're in, crisis, we're not thinking as clearly as we might. We're not thinking of all the things in your toolbox. And so having safety plans with, I think, if you have clients who are in substance use treatment, even having a safety plan, I think is a great idea. It might not be necessarily for suicide, but some sort of crisis. And then I also wanted to note that sometimes we hear about safety contracts, which are like a document. It's not obviously legally binding, but it's like a document that you have a client sign that says basically, I won't attempt suicide. Those are ineffective and often sort of harmful. So we really want to move away from those and towards safety plans, which are actionable, are not punitive. You're not saying like, I'm going to be in breach of contract if I, attempt suicide. So I think learning
Well,
about
I think
safety
I like
planning.
that you bring that up. It's collaborative. It's the
Yes.
patient. You're just working with the patient to come up with some solution based, things that they feel like that they could do, and
Mm-hmm.
and just some forethought. Like you said, all we're trying to do is maybe buy some time in that 5 to 10 minutes of that impulse till maybe this feeling just might pass. What could you do in that 10 minutes to fill that space between that thought and that action? Is there something that we could do in that space? And
Mm-hmm.
I think that's what we're trying to do, is help them create some space.
And I think whenever you're working with a patient or a client and talking about suicide, being aware of your own feelings about suicide
Yeah.
before you have those conversations is important for everyone, be it if you're a friend or a clinician or provider, because, sometimes we will subtly convey to someone that we're uncomfortable talking about suicide, we're afraid of it, we don't want to hear, maybe might say like, you're not thinking about suicide, are you? So like these questions that sort of, that the answer should be no, right? Like the answer that the person is looking for is no, I'm not. So thinking you're in yourself about, what do I think about suicide? How can I maybe put those feelings aside if I'm talking to someone and listen in a non-judgmental way, rather than bringing these unconscious or conscious biases to that conversation with them.
That's really important training, because I think we all carry our biases, and not being aware of them can really lead in these really difficult, sometimes, conversations that we're recognizing. And one suicide prevention training that I attended, it talked about, sometimes instead of, are you suicidal? It was like, are you going to kill yourself? Like, we need to use very direct and plain language as well when we're doing these screenings. And exactly like that, instead of trying to just kind of go around and be delicate, because like you said, so that we're not acting that we're uncomfortable, we need to just be gentle but be direct and coming in so that they feel safe, and leave it open for them to be able to discuss how they're feeling.
Yeah, and I really appreciate, Ray, that you advocated for every practitioner to ask about and screen for suicide every single encounter, because I think we get into this guessing game in medicine and behavioral health of who we think is going to screen positive and who's not. It's like, well,
Yeah.
you really need to ask this person about suicide. They're fine. They're this gender, this race, this ethnicity, this, socioeconomic class. And I've learned from experience that that's just not true. We're terrible guessers. And I don't know if there's any clinical data behind this, but in fact, I think it was from the podcast. I don't know who we were talking to about this, or maybe it was a training. But I made the commitment to myself to ask every single person at every encounter, even no matter how busy you are and like you're out of time. And I'm amazed at how many people will say yes that I never would have guessed would say yes. And so I've just got to really check my ego at the door and make sure I'm not coming in with preconceived notions of who is having suicidal thinking or was in the last couple of weeks or could be, because we're wrong and we can't possibly imagine what people are experiencing or thinking. So got to just ask in plain language. And if we're not comfortable, go to these trainings, go to more and more of them until we get more comfortable, because it's so important, because people, people die, young people, old people, everybody. It's non-discriminatory. So
I think that's so important, Paula. And sorry, there was one other thing I was reading. It was just such an interesting, I was reading this table, and it was just talking about, back to what you were talking about, Ray, when you're saying protective and, so the protective and then the risk factors for suicide. And one of them, Paula, was when somebody has a change in either their social status or their financial status. And those are not things that are visible, right? When a patient comes in to see you, you don't know if somebody had a significant financial loss and they don't come in and just tell you that, or if they had, a major upset in their social situation. And it's like you said, you might just be, well, this person, I know them and they should be doing really well, but that's a significant risk factor for suicide. So that's great advice, that we just have to do it, because we don't know about those things.
And there is research about that. And providers, clinicians are really bad at
we profile.
identify. Yeah. And this is in the context of some researchers are trying to create algorithms that can help with this, which is great, I think, as a supportive tool. But I also think having a culture where we just ask everybody, where we screen everybody, it normalizes it to our patients as well, right? So it's normal to talk about how you're feeling, if you're feeling suicidal, or, to have practice in sharing those things. And practice it maybe in situations where you're not in crisis, so that when you are, you maybe have language to talk about it. I strong advocate for lots of screening.
that's an excellent point. I love that point. Thank you so much.
Well, Ray, thank you so much. It's been such a pleasure. And thank you for all of this information. We always learn so much. And we appreciate your time and your efforts in this really important area. And thank you so much, and have a great night.
Thank you so much for having me.
Ray.
Until next time. Hey, check us out at theaddictionfiles.com or email us at theaddictionfiles@gmail.com. Thank you so much to Ricky Valades for use of his song Awake. Check him out at rickyvalades.com.
Podcasts are for entertainment and education purposes only. Hosts and guests are not responsible for any harm caused by information obtained from this source. As each person is unique, you're advised to seek the advice of your own healthcare professional to treat any medical conditions you may be having. Opinions expressed on the show are those of the Addiction Files and not of our respective employers.